to this collaboration, PowerStar collaboration with IVUmed. It's a series of professional lecture. Today, Dr. Jeremy May will be taking us on reconstruction of posterior urethral stricture. We are delighted to have you in the house, sir. I'm sure more people will be joining as the lecture proceeds. So I think you can, maybe you can share your slides.
Are you guys ready to go? Okay, great. So I'll share my screen if that's okay. Oh. Well, it's really a pleasure to give you this lecture. My name is Jeremy Myers, and I am from University of Utah. And Utah is where IVUmed was founded by Catherine DeVries. And so I've had a close relationship with IVUmed over the years. So it's really a pleasure to give you this lecture. Utah sits in the west of the United States. It's a large area. And it can take about 8 hours to travel from one side to the other, and it's about 500 miles in distance from corner to corner. Being Western, we see a lot for the United States of pelvic fracture urethral injury. On the other hand, the number of pelvic fracture urethral injuries that occur in the United States have gone down over time as auto safety measures have increased, and that's been shown in our national trauma databases. And also the number of pelvic fracture urethral injuries is really dwarfed by countries such as China and some countries in Africa or Mongolia, where I've traveled, where patients can have a lot more exposure to work-related injuries and auto-related injuries. So even being one of the busiest centers in the US for doing pelvic fracture urethral injury, I repair about 6 to 10 per year. And when I've traveled to Rwanda or to Mongolia, we'll typically repair in one IVUmed workshop up to 15 of these injuries in just a week or 2-week time frame. So I think that it's an expertise that's really needed in a lot of countries in the world. We have a lot of rodeo in Utah, and we see a few injuries from these rodeo injuries every year, but the vast majority are from motor vehicle accidents and those types of injuries, more mundane. So this is where University of Utah is. The hospital is kind of up in here, and it's a very mountainous region. A lot of snow, cold weather in the winter, and it's quite desert in the summer. And so this is my backyard, which I'm really lucky to have, and might be a little bit different from where you're coming from. So I'll start this off just with a case that we would see typically in the United States. So, and this will kind of review some of the considerations or the ways that I think about pelvic fracture urethral injury, or another synonym that's in the literature is pelvic fracture urethral distraction defect. This is a 35-year-old male who presents to the ER after a motor vehicle accident. He was restrained, but they were at highway speeds. He has a non-operative splenic laceration, pelvic fractures. He's stable, and he's transferred from an outerlying facility via helicopter. And we cover a really vast geographic area. In the Intermountain West, there's about 30 million people. But the area covers about 1/5 of the geographic United States. And so University of Utah has about 5 helicopters and a couple of fixed wing aircraft to pick up patients at various hospitals throughout this really large region. So this is the fracture that you see. The patient has pubic symphysis diastasis, and then also an inferior rami fracture, which you can see right here, and another small fracture, it looks like over here. So there are all different patterns that can lead to these urethral injuries. And this was a paper from Dr. Devine from the 1980s that tried to look at which fractures cause the injuries. And it turns out there's just a ton of different fracture patterns that can be associated with the injuries. One of the nicest papers, however, really looking at this was from Dr. Hunter Wessels, who's the chairman at University of Washington. And what he did is he looked in a multivariable analysis at patients that had pelvic fracture urethral injury and those that didn't, and he looked at what fracture pattern was associated with the injuries. And it turns out that pubic symphysis diastasis is highly associated with the injury. And if you had more than a centimeter of diastasis or pulling apart, the odds were 11-fold that you would have a urethral injury. The other injury pattern makes a lot of sense. It's an inferior rami fracture with distraction. And since the urethra, the membranous urethra lies right there in between the crus, it makes sense that a distraction defect there could tear the membranous urethra right off the prostate. And that, if you had more than a centimeter of distraction of this injury, inferior rami injury, the odds were 6.4-fold. So these are the two patterns that really come up. Although I have to say, I see the injuries happen with all different kinds of fractures. And so I don't necessarily really use this clinically. It's more of the way the patient presents with blood at the meatus and the signs of a pelvic fracture urethral injury. So what's the classic sign? Blood at the meatus, a high palatable prostate. And that means that the prostate is kind of filled with blood behind it, and it's kind of spongy when you do a rectal exam. However, I don't think that a rectal exam in the acute trauma setting is very practical. These patients are usually immobilized because of their cervical spine. They need to get x-rays. And primarily, a rectal exam is done to see if there's blood in the rectal vault. And I don't think in that position you could really feel the prostate. So the vast majority of the times for an astute trauma team, it's blood at the meatus that indicates there may be a urethral injury. So how do you assess this? And the easiest way to assess this is to do a retrograde urethrogram. And this is a retrograde urethrogram combined with a cystogram that shows a urethral transection here. That's a full transection. And this can be done with us in radiology, or it can be done sometimes in the emergency department with a C-arm to confirm the injury. Another way that you can confirm the injury is to gently try and pass a catheter. If it goes into the bladder, great. You've gotten the patient kind of out of the ER and handling their other acute problems. Or another way is to do a scope. If you have a flexible cystoscope and you're able to look in the ER, you can look and see that there's a full injury. So this patient, so the trauma team sees blood at the meatus and calls urology for management. So how do you manage this, and where are these injuries occurring? So the injury occurs in the posterior urethra. But the posterior urethra doesn't refer to anatomic relationships. So it has to do with the embryonic origins of that portion of the urethra. It's not that this urethra is more posterior in the body than the other urethra, but the area of the injury is right here in the membranous urethra between the prostate and the bulbar urethra. The acute presentation, where do these patients come from? What are their injuries? 98% of them are associated with pelvic fracture. I have never seen a pelvic fracture urethral injury other than from penetrating injuries, from a gunshot wound or something like that, that wasn't associated with a pelvic fracture. It occurs in 5 to 10% of all traumatic pelvic fractures. In this paper, at least from the US, and it was a combination with some data from Russia, There were motor vehicle accidents accounted for 90%, but the other kinds of things that can account for it are being crushed by something heavy, or having a long fall, being crushed by livestock, being hit by a car, etc. And typically these patients are severely traumatized. And so this is a patient that had a pelvic fracture urethral injury during my fellowship. And this is the typical scene. You can see massive lower extremity trauma. He has a catheter that was successfully placed into the bladder, as well as a suprapubic tube with lots of blood. And so these are not usually subtle injuries or isolated pelvic fractures. Typically they're in the constellation of major trauma events. So this is also a common way of diagnosing the strictures. So this is a patient transferred to University of Utah, and you can see the Foley catheter was not working for a very good reason. So a Foley catheter was placed at an outside facility and is just sitting within a hematoma. Of course, the concern is that this could convert a partial injury to a full injury. I'm not sure that makes sense to me. I mean, if the urethra is stuck together, I don't see that a catheter going out into a pelvic hematoma is necessarily going to tear it further, but it's obviously not good. And when you irrigate this, I mean, you can irrigate the hematoma pretty well and get some fluid back. It may not feel quite right. But if you're pretty dedicated about irrigating, you can get fluid back, and it can seem like it's within the bladder, just not quite right. This is a full transection, and here you see the bulbar urethra laterally going up to kind of the urogenital diaphragm. This is maybe just proximal to the external sphincter, and a bunch of extravasation. So full transections account for about 66% of the injuries in the literature. Here's I'm sorry, this is a little bit dark, but here is a partial injury. And so this is an AP, so that's why this bulbar urethra has a very weird twist in it. That's normal for an AP shot. Sorry. And you can see that there's extravasation of contrast here. So there is an injury, but there's contrast that goes up here. Here's a verumontanum, the prostate, and into the bladder. So you know by definition, this is a partial injury because contrast went past the injury into the bladder. So about 33% or a third of the injuries. Here's another sign of a partial injury. This is a patient that had pelvic fractures that were suspicious. The patient had blood. They had a cystogram that was negative, and a catheter passed into the bladder. But when a pericatheter retrograde urethrogram, or just from the cystogram, there was some extravasation. And so you know this patient has a partial injury and can be treated probably just with a Foley catheter for 2 or 3 weeks to allow the injury to heal. This is another classic X-ray that I always show, and it's what's called in the literature the pie in the sky bladder. And that's, I think, in reference to an old song from Frank Sinatra. And this bladder is pushed out of the pelvis, and it looks, it's up completely, but is not detached. And so there's lots of pelvic fractures, but the prostate's still here, and the bladder and prostate are probably fine. It's just detached from the bulbar urethra. So in this patient, what's our goal for management? And our primary goal for the acute presentation of pelvic fracture injury is to establish bladder drainage. And you don't have to worry about realigning the urethra. These patients need to be stabilized before you would consider doing something like a realignment. The easiest way to do that is just to place a suprapubic tube. And that should be done with the radiologist by ultrasound guidance, or just by aspiration of the full bladder, etc. Any method that's can be done in order to establish bladder drainage is appropriate. So what about the location of these injuries in regards to the prostate? And the old dogma of this injury was that the prostate tore off the membranous urethra, but it turns out it's really probably more of a spectrum. And these injuries can occur anywhere along this length. They can be primarily bulbar with sparing of the external sphincter. They can be at the apex of the prostate with sparing of the external sphincter, and you would scope and you see the external sphincter and then the injury. So it can really happen all along here. And I think it's very individual. It depends on the pelvic fracture, and it also depends upon the ligamentous attachments to the pelvis and where they tear the prostate. You know, anybody that does prostatectomies knows that that can be kind of variable. You know, those puboprostatic ligaments can be real consistent, or they can kind of be fan-like, and they vary from person to person. So the evidence for this is a couple studies. This was one from Dr. Mundy in London, and he looked at 20 men after urethroplasty. And he did a very simple test, which he asked them if they could stop their urinary stream once they started after their urethral repair. 85% of them were able to stop their stream. And obviously that's evidence of external sphincter function rather than internal sphincter function at the bladder neck. And then 65% of them had visible sphincter. And this is a picture of the repair, not a perfect repair. There's a little bit of stricture, but it's pretty open. And then this is the external sphincter just beyond the repair, showing that in this case, it was primarily a bulbar injury right on top of the sphincter, but not involving the sphincter complex. Dr. Makinich at UCSF also confirmed this using urethral pressure profiles, and 8 out of 12 were able to increase their urethral pressure at the area of the external sphincter. So how do we treat, what are other options once we've established suprapubic tube? There's 3 things that you could do to realign the urethra. One is primary sutured reanastomosis. And so this is when a trauma surgeon will open up the perineum and try to repair with stitches the urethra to the prostate apex. There's primary open urethral realignment, where you open the pelvis and using catheters or sounds, you try to realign the urethra and get a catheter across the defect. And then there's endoscopic realignment, where 2 scopes are used, one from above and one from below, and you turn off the light of one scope and you can see the light of the other scope, and you can grab a wire or grab a small catheter and pull it out and get through and through access. So what about primary sutured reanastomosis? This is something I've seen a lot. And in Mongolia, there was many patients that would come in that underwent primary sutured reanastomosis. And it obviously makes the job much harder to repair the injury. And the problem is everything's really torn, and it's hard to tell what's viable and what's not. And there's a lot of distraction from the hematoma that makes putting the 2 ends together very challenging. And obviously it's a dangerous situation for bleeding. When you open up that tamponade effect in the pelvis, you can get really dramatic bleeding. And so this is not something that's done or recommended because of the high restricture rate and the danger to the patient. So this should not be performed. Primary urethral realignment, we talked about what the idea is, that you can decrease stricture if you get a stent or a catheter across the injury. How is it done? This is kind of the old way of doing it, where you would use 2 magnetic sounds, one passed from above onto a finger or onto a magnetic sound to kind of pull through, and then pull a catheter through, tie to a catheter and pull through. And you know, I imagine that a lot of you perform open prostatectomy for adenoma. And obviously, when you do this, doing a suprapubic prostatectomy, you fracture the prostatic urethra and the bladder neck before you ream out the prostate. And so you really probably disrupt the sphincter mechanism pretty substantially. And so this is not the method to use. A simpler method is quite easy to do if you have an open pelvis, and that's to pass a catheter into the hematoma, find the catheter and pull it into the field, and then pass a catheter from a cystotomy out the prostate, find that, and then tie the two together, and then you can pull this catheter retrograde into the bladder, and you've accomplished the realignment. So, you know, this is something that's really debated by urologists that are interested in trauma. Does it actually help? And people come down on this, both sides, really strongly. And the issue in my mind is that the evidence is quite conflicting. So this is an example of the evidence. This is from Egypt, from Dr. Kouratim, who's done probably more urethroplasties than almost anybody in the world. And he did a meta-analysis of different studies at the time. This is quite an old study. And he found those undergoing realignment had a stricture rate of 53% versus 97% that underwent suprapubic tube. So you would conclude from this that you could reduce strictures by 50% if you did realignment after the injury. And that sounds very worthwhile if they could avoid a urethroplasty in the future. The problem with these studies is that there's what we call bias, inclusion bias. And so in patients that underwent realignment, many of them may have had partial injuries where the catheter went right through to the bladder, and that was called a realignment. Or a urologist did a scope and was able to transit the injury pretty easily into the bladder, and a catheter was placed retrograde into the bladder. Those patients that had a suprapubic tube, sure, many of them probably didn't have an attempt at realignment, but many of them may have failed, or the surgeons didn't try to do any realignment because they thought the injury was much more severe, and so they have a worse outcome. So the studies are fundamentally flawed because there's no randomization, there's no difference in the protocols. So how do you do endoscopic realignment? The way it's done is this is a patient that had an open pelvis from repair of the pelvic fracture, and then also had a bladder injury. So we advanced a scope retrograde, and we had another scope that's not depicted here, and we followed the scope out into the urethra. And then we have a small catheter, a wire's passed, and then a council tip catheter was passed over the wire into the bladder. And that's how you do an endoscopic realignment. I think that you probably need a flexible scope to do it. I think if you have one rigid scope in the urethra and a flexible scope going from above, via a small incision like this, or just a puncture into the bladder, like a suprapubic tube sheath or something like that, that could work. But I don't think you could make the bend with two rigid scopes. So if you look at more contemporary studies, this was just a prospective study from Brian Volsky and Dr. Wessels at University of Washington. They looked at 19 patients that underwent endoscopic realignment, and their orthopedic surgeons there insisted on realignment. They thought a suprapubic tube would cause infection, and so this was really their practice based on the orthopedic surgeon's fear of infection. And they found that the total success was 3 out of 19, 16% success, that patients didn't need additional surgeries down the road. And 2 of those successes had a known partial injury. So a much different view than that meta-analysis by Kouratim. I looked at this in the first few years that I was at Utah and had very similar experience. And so I found 2 patients that were successful out of the 10 patients we treated primarily during that time frame. And so about a 20% success rate and only in partial injuries. So I was quite skeptical that this actually did anything. So we designed a trial that looks at suprapubic tube versus realignment, and we're just starting to report the outcomes of this trial. So suprapubic tube alone with delayed urethroplasty versus urethral realignment. This was through the American Association for Surgery of Trauma, and we basically tried to compare apples to apples, meaning the same types of patients that had bad injuries. And so one group would get suprapubic tube alone. We tried to place a catheter, and then we would also attempt a retrograde cystoscopy. And if that failed, we couldn't easily go past the injury, just a suprapubic tube was placed. In the other group, patients that couldn't get the catheter placed retrograde had an above and below cystoscopy to realign the urethra and have a catheter placed across the injury. So it turned out we enrolled 41 centers across the United States. And for your reference, this is Utah, right in the west here. This should elevate the evidence from very low level evidence that we currently have to a prospective cohort study, which is level 2A evidence. So those results should be available in the next year. We've just started to analyze, and we've stopped the trial. We've accrued all the patients that we are going to accrue. It doesn't look like there's much effect, though, to realignment. So how do we classify these injuries? The injuries are classified as it's a fairly simplistic. They're either simple or complex. And this was the original Turner-Warwick classification, who kind of described the elaborated urethroplasty. Complex ones are lengthy, there's bone fragments mixed in with the tissue, there's fistulas to the rectum or to the skin. Here's a perianal fistula from an injury of the urinary tract, and then there's large diverticular cavities, and all of these things are really common with severe pelvic fracture. So here's an example of a complex case. This is a patient that had an open pelvic injury with a lot of dead tissue that was debrided over time. And this is my finger, and this is the finger going right into the urethra, right at the prostate apex. You can see the sphincter complex, and this is the start of the viru leading up into the prostate. And actually, this patient healed without any scarring, just with a wound vacuum and a suprapubic tube, and he didn't require any surgery. And you can kind of see why. Most of the urethra, at least half of it, is really intact. And so this was surprising to me, but it was quite amazing that this patient healed no problem. So how do we do the surgery? So how do we figure out what surgery we're going to do and how bad the defect is? So the most important study often is a retrograde urethrogram, and often we'll get studies like this. And it's really important. A novice will say, oh, wow, this is a huge defect. How are we ever going to connect those? But this is just a patient that hasn't had their posterior urethra opened up. And you can see the defect is actually fairly small here. And it's just that you need a more forceful cystogram phase in order to see the defect. One thing that's been really helpful in the last few years, and people have been popularizing this idea, is to get an MRI. And they have these MRIs now to look for prostate cancer, and you can really delineate the membranous urethra. This is a normal MRI. So bladder up here, the prostate, and then the membranous urethra right here. This is the bulbospongiosis. The corpora spongiosus, and this is the urethra coursing right through here. And here's what it looks like in a patient with an injury. Sorry, it's a bit blurry. but this is the apex of the prostate, and here's the apex of the urethra. And so this is the pubic bone in cross section. So you can see that the top of the prostate is tucked way behind the pubic bone in this patient. And so the MRI gives you an idea of, wow, this is going to be challenging. We're probably going to have to cut out a lot of this pubic bone in order to shorten the tract in order to make these two ends meet. So what are some risks? ED is very common in these patients, and the literature is all over the place, but about 25 to 60% of men have ED. Many of them do get their erections back over time after the injury, but that's quite variable, from 7 to 66% in the literature. This was a nice paper from Israel, and it looked at 25 consecutive patients, and they looked at nocturnal penile tumescence to measure erectile dysfunction. And they found out that 72% of men had ED, even though some didn't report it to their clinicians. Nice part of this paper too is they noticed that men that came 6 months after injury had much less likelihood of having ED. There was 60% of men with abnormal nocturnal erections when they presented 6 months post-injury versus 80% before injury. So this kind of tells you that timeline of improving erections over time. We looked at this in the TERNS network, which is a cooperative research network in the United States. And we gave the patients the sexual health inventory for men. And we found that in our patients, at least, which were about 120 patients, there were about 60% with severe ED and another 20% with moderate ED. And after urethroplasty, that increased to 70% with severe ED and about 20% with moderate ED. And for me, when I'm counseling patients, it's kind of a relief if they have ED beforehand, because you know you're not going to induce it with the surgery. When they have good erections before the surgery, they're at very high risk for losing their erections after the surgery. And obviously that can be pretty devastating for a young man. So the surgical approach, it's a perineal approach. It's known as the elaborated perineal urethroplasty. We use hyalothotomy and a perineal Bookwalter, but you don't need these necessarily to complete the surgery. We have these extended candy cane stirrups that are quite long, and then the patient's put into this position. So their legs are not cranked backward, they're just kind of hung there. And any nerve injury is really rare with this injury, as long as you're not really putting force backwards. The way I've done this in other places that don't have candy canes is just an under the calf stirrup that's more common, you know, an Allen type stirrup, and then just really separating them and pushing them back a little bit, and you can get very similar position. There's a bump underneath the buttocks to rotate the perineum kind of up towards the surgeon. This is the perineal Bookwalter, and I don't think you need this for men that are normal size. It helps for kind of the American construction worker that's really large, and you can get really good retraction with fixed retraction. Lone Star retractor works well. There's a number of different types of retractors. So the first step is to mobilize the bulbar urethra. We often will do a lambda incision, but sometimes you can get away with a straight incision. And then you need to completely excise all of the fibrosis. So this is a sound that's been gently passed from above into the prostate. And you can palpate the sound in the perineum once the bulbar urethra has been transected at the fibrosis and kind of retracted upward. And then you can cut with a knife onto the sound and gently remove all of the fibrosis until the sound comes into the field. You don't want to pop the sound through. You can do that very easily, but what you really want to do is remove all the abnormal tissue and just use the sound as a guide for doing that. Sometimes those sounds are hard to pass. You have to have a suprapubic tube that's in the midline. And if you don't have a suprapubic tube in the midline, it's better to make a cystotomy. And then you can just open the bladder and pass the sound under direct vision right through the prostate and know that you're in the right spot. What you don't want to do is mess around a lot and then cause a lot of false passages, bleeding, etc. And that can really complicate the repair. So step one, the bulbar mobilization. Step two, if you can't get good length down here, is to separate the corporal bodies. And so what you do is you bovie or use a knife to cut down to the pubic bone, and then you can elevate these corporal bodies off of the pubic bone. Sometimes you get into one side of it and you see the spongy tissue and you have to oversew that side, and then you expose the entire pubic bone. And if you still can't get good length, especially if the prostate apex is up here underneath the pubic bone, then you need to core out this inferior portion of the pubic bone. This won't have any consequence for the patient. They won't even know if you did this the next day. It doesn't cause more pain than the surgery does, and it doesn't destabilize the the pelvis, because there's lots of pubic bone that's left. This is what we use. We use a burr saw to do that, called a Midas Rex, but you can also just use an osteotome, a hammer, and a rongeur. That works very well, especially if they've been recently sharpened. So the fourth step is corporal rerouting. And so the concept there is that there's still not enough length. And you can kind of see when you need to do it, because when you're pulling this down to the prostate apex, it's kind of bowing and twisting the penis. And that kind of gives you an idea, yeah, I could get something if we did the corporal rerouting. And so you pull one of the corporal bodies off the pubic bone completely. This is on the right side of the patient. And then you groove out using your osteotome, another groove underneath that corporal body to make a trench for the urethra to come down to the prostate apex. It's pretty rare that I have to do this. I've only done this maybe 4 times, and it has helped when I've done it. Webster at Duke University really popularized this, and he used it a lot in up to 40% of patients. Some fellows published a study in the United States after this in 2007, and they only used it in 4 out of 142 patients. And those patients, 3 out of 4 restrictured. So I think in their hands, they didn't find that it was needed. And I would have said that until the last few years, but I have found several cases where it really made the difference, and it made a big difference in being able to connect people. So I think it's something you have to keep in mind that might be needed. And the final is the anastomosis. This is our prostate apex with concentric sutures placed. We usually place 12 sutures, but you could use, 8 sutures, something like that. In really deep ones, it's very helpful to have a double-armed needle. We use an RB1 type needle. It's a taper, a small needle. And sometimes it's very challenging to place these stitches if it's really deep, and so a double-armed suture can help. And then the urethra is tied down. We typically do a VCUG at 4 weeks, and then we will leave the suprapubic tube in, change it to a fresh one for a couple more weeks. We plug it, and then if patients are voiding well, we take it out. What are the outcomes? This is a meta-analysis that we did probably 10 years ago now or more, looking at all of the published studies, and the outcomes are excellent. The perineal outcomes, as defined by needing to do any other surgery, such as a dilation, etc., was 94% in the literature. This was we did this also with turns, and we found very similar success rates, 91% success rate in these patients. So it's a very effective surgery if you have experience with doing the elaborated perineal approach. So key points and my conclusion: posterior urethral strictures, they're strongly associated with certain pelvic fracture types. The immediate management should be suprapubic tube placement until the patient's stable. And most posterior urethral injuries cause simple strictures that can be managed with perineal repair. And the success rates of perineal posterior urethroplasty are greater than 85%, probably more like 90% in experienced hands. So that's my talk, and I'd really love to take questions and kind of, I really appreciate being able to give this talk. It's really nice to meet you all, at least virtually.
Thank you, Dr. Jeremy Myers. Quite enlightening lecture. No doubt PFUD is very challenging for most urologists. And he tried to highlight some of the challenges. So we just go to the question and answer session. You may indicate by sending your question to the chat box, please. Now, while we are waiting for that, I don't know whether I can make some comments. Dr. Jeremy, can I make my comment straight away waiting for others?
Yes.
Okay. The issue of the primary realignment and the endoscopic realignment. Well, the challenge we have here is that a lot of our patients are actually multiple injured and with life-threatening injuries. And because there are very few trauma centers before they get to the tertiary hospital, usually their condition is so bad. So the emphasis at that time is here to save the life of the patient. So most of the time, what we tend to do for our patients is just the SPT, that's to put a suprapubic tube, while we try to salvage other injuries. Some of them actually have a bowel injury associated, some with spinach injury. So in such patients, we don't think of endoscopic realignment at all. Very few of our colleagues actually do this. So a lot of our patients actually have SPC and delay realignment, maybe now about 3 months or 6 months, as the case may be, depending on how long it takes for the other associated injuries to resolve.
Yes.
So that is one. The second challenge is the issue of failed repair. What you have presented are primary cases.
Yes.
We have a lot of these conditions are usually with a lot of with high failure rates. So most of the urologists in tertiary center get referral from other places where it has failed, and you know that once there's a failure, it's always difficult. I don't know whether you have want to share your experience with us about failed repair following a PFUD.
Well, we're very lucky in the U.S. in that these patients are referred to really probably about 20 tertiary centers where there's a reconstructive urologist that does the cases specifically for pelvic fracture, urethral injury. So most of the time what we're dealing with is primary repairs where you have a very good chance of success. My primary experience with secondary repairs is traveling and teaching how to do the pelvic fracture urethral injury. And the principles are exactly the same. You know, the tissue is obviously more atretic, it has less blood supply, and the failure rate is going to be higher. Sometimes the urethra is in good shape, sometimes it's in really poor shape. There's a variety of very advanced things that you can do to salvage. And people have talked about that in the US. You can do a free intestinal flap. Dr. Mundy talked about a sigmoid colon flap. That's a tube that's dropped down and will substitute for a lot of the urethra. If you've had necrosis and failure because of lack of blood supply from the primary repair, but all of those are really advanced techniques. So it is a huge problem going and doing a secondary repair. And I think the principles are about the same. I wouldn't change anything at all.
Yeah, thank you very much. So there's a question in the chat box. What are the options after the first attempt of failed attempt of delayed realignment? I think Dr. Edward is asking that question.
You know, so we've found, I didn't present this data, but that cohort study where we compared suprapubic tube to realignment, there was no difference at all. Almost everybody strictured. And so I really would encourage probably just placement of a suprapubic tube alone. And so if you're talking about urethral alignments, Emmanuel, during the acute phase, you know, if you're a believer in that, you certainly can try. But if you're not able to accomplish the urethral realignment, I would just quit and put a suprapubic tube in and then wait and do the repair at 3 months.
Thank you very much. What's the experience with PFUD in the pediatric age group?
Oh, so that's a very challenging age group. So we do all of the pediatrics here at, we have a children's hospital that's attached. And so I do have some experience with it. In the literature, pediatric patients do not do as well. And maybe it's because they survive more severe injury and they have worse distractions. Or maybe it's just that the tolerance for failure, because it's so much smaller, is lower, and then you get a failure. We've had good experience using the same principles as in adults, and we will operate on kids, you know, down to 6 years old, 5 years old. If they're really small and you don't think you can be successful, one option is to wait. You know, you could leave a suprapubic tube and wait until the patient grows and then do the urethroplasty later on. We've considered that, at least in really small children, although we've always fixed the injuries. Nothing different about the principles of the surgery, though.
Okay, thank you very much. Any idea of the impact of delayed repair to the outcome?
Meaning delaying 3 months or delaying longer than that?
Delayed 3 months, delayed 6 months?
I think that we typically will repair at 3 months as long as the patient's stable. But to your point, some patients are not healed by 3 months. They may have severe injuries and be really recovering for up to 6 months. Patients need to be nutritionally optimized. They need to be eating well, eating protein, recovered from their other injuries before you do the surgery. But I think 3 months is adequate time to do the repair. Other people have talked about doing it earlier. Ronaldo Gomez in Chile has talked about doing it at 6 weeks or doing it at a month. And I've tried to do some repairs earlier and I've really regretted it. I think in some patients it could be fine, but 3 months is a safe window where almost everybody will be good for the amount of inflammation they have.
All right, thank you very much. There is this dogma that once you suspect PFUD, never make attempts at urethral catheterization. So what's your opinion about making a single attempt at catheterization and against no catheterization at all?
Oh, I think it's fine to try a simple attempt, you know, particularly if it's someone who knows what they're doing. You don't want someone just jamming a catheter in and trying to get it across. But if it's a urology resident or a urologist or a trauma nurse or surgeon that's going to be careful, I think it's appropriate to try and place a catheter. If it goes into the bladder, it gives you great information and you have the problem solved as far as the acute time period because you have a catheter in draining the bladder. So we always try one gentle attempt at catheterization. Manipulation though, other than having a scope and looking through the area, I wouldn't do.
Thank you very much. What's your opinion about tissue substitution in the posterior urethra, like using the buccal mucosa grafts?
So it's generally not applicable because if you think about if you can't make the stretch, you have exposed pubic bone, you have done a pubectomy typically, and whether you can get graft to take there, and the urethra is completely obliterated. So you have to have at least one side of the urethra that stretches down, and then I'm not sure what the buccal graft would add. If you have necrosis of the urethra, like a repair that fails, then you may do a two-stage urethroplasty where you put down buccal graft and then you roll it up a year later. And that can work well where the patient has a perineal urethrostomy for about a year while you wait for the graft to mature, and then you can roll it into a tube later on. So for primary repair, I don't think it has much function at all. It's always an anastomotic repair. For secondary, it could be helpful.
Thank you very much. Is inferior pubectomy step, is it always mandatory? Inferior pubectomy.
Yes. What is the question?
That's the question. Is it mandatory in all cases as one of the steps?
No, not at all. And a lot of people will say the way it's been described is that inferior pubectomy allows you to gain additional length to make the gap, but it doesn't in everybody. So a lot of times the prostate will be dislocated posterior towards the rectum. It'll be more in your field rather than under the pubic bone. And when it's put posterior, then doing a pubectomy doesn't do anything because it's actually in your field already. It's when there's dislocation kind of up and behind the pubic bone, that's when it really helps a lot. So a lot depends on the position of the prostate apex. It's a really good question. So it's not mandated. In most of the injuries in the US, we don't have to do a pubectomy. It's probably 10–20% that we're doing a pubectomy for.
Okay, so just additional to that, are there instances where you have to do a combined approach, abdominal and perineal? Are there conditions we have to do that?
Yeah, I have not had to do that. And I think that you can accomplish basically everything from the perineum that you would need to. And so the only time I would do a combined approach is if you have to open the bladder, and it's really not doing much other than opening the bladder so you can place the sound under direct vision if it's not dropping in where it should go, or the SPC is off to the side and you can't put that sound in. So I know that it's in the literature, the combined abdominal perineal approach, but for pelvic fracture, urethral injury, I've never had to do that. I think you can take out enough bone and get enough space from below.
Thank you very much. Somebody's asking the type of urethral catheter, does it influence the outcome, silicone versus Foley's?
You know, there's been just a few studies about that, and I think that silicone induces less inflammation. I think authors have said that. So we used to use silicone, but the catheters we have, they were very soft, and they stopped making those catheters. And now the silicone catheters are very hard, and they're very uncomfortable for the patient, at least the ones that we have. So we went back to using just latex catheters. I think you want a soft, flexible catheter, whatever you use. And I don't think it has much influence on outcome. So I don't think it matters too much which type you use.
Thank you very much. All right, somebody is asking if you have done MCUG at the time of presentation, is there a need to repeat it at 3 to 6 months when we are considering the repair?
Yes, I think so. because it'll give you a very good idea of how much of a gap there is. In the acute presentation, you're mainly seeing whether there's an injury, whether it's a complete injury, it's for diagnosis. In that 3 to 6 months, when you're planning the surgery, you want to know if there's misalignment or if there's a really long gap. So I would repeat it before doing the surgery.
Thank you. Somebody is asking, during your repair, as the anastomosis now, do you always spatulate?
Always.
And do you have preference for particular sutures?
So I don't think it matters what suture you use, but I would not use chromic. I don't think that would last long enough. So I would use a vicryl suture. We use a longer absorbing suture called PDS here, but I think vicryl or PDS or monocryl would all be okay. And I use a 5-0, but I think a 4-0 should work fine. And bigger suture than that, I think is probably maybe a little bit too rough. So I'd recommend 4-0.
Okay, thank you very much. Some of these patients develop perineal fistula thereafter. How do you undo them?
Could you repeat it?
Some of the patients that develop perineal fistula afterwards with this, how do we undo it?
Oh, well, I think you need to allow adequate time for the fistula to mature and the inflammation to go down. And so I would be thinking about 6 months for repairing the fistula. If the urethra is open, there's no rescarring and it's just a fistula where you had breakdown, you can, pass something in the fistula, core it out, open everything up, get good exposure. And one thing you can consider is using a muscle flap in order to kind of bring in healthy tissue and really seal the area. I have used gracilis muscle for pelvic fracture urethral injury, where there's been a lot of kind of empty space and I didn't want the urethra rescarring because of that. And so the gracilis muscle flap from a plastic surgeon colleague could help with that type of case, but it's a tough problem.
All right, here's another difficult one, or not common rather, PFUD in females.
Oh yeah, so we have seen a few of those. You're right, they're very uncommon. And that's a different type of injury than in men. And if the patient is stable, you should attempt a repair. And you can do it perineally, transvaginally, but you should try to fix the urethra. Typically, what's also disrupted is the bladder neck. It goes hand in hand. When you get a posterior injury in women, it usually involves the bladder neck. And the danger is those patients will be really incontinent if they're not repaired in the immediate time period. You don't have to do it the day they come in. I mean, you can wait until they're stable and take them after a few days after their injury, but I would try and fix those perineally.
Thank you very much, Dr. Jeremy. It's been nice having you around. It's been quite an enriching lecture. Now, somebody is asking finally, for third world countries, we have a long waiting list. I don't know if you are aware of any available grants that can assist the training of more of our urologists so that the waiting list can be shortened.
Well, I think I would turn to IVU. That is one of their big missions, is to obviously train urologists that have the capability of doing reconstructive surgery or oncology or whatever expertise they need, and then having centers where they can train others. And so I'm not aware of any grants other than the teaching workshops that IVUmed does. And there are many, many sites that they work in Africa. I've been involved with Rwanda primarily through IVUmed and also the Society for Genitourinary Reconstruction, and we partner together. and I know some of you on the call are from Sayachka. So, you know, that's, I would say, approaching IVU or some other organization that has a similar philosophy of training focus rather than going and just doing cases. That's really the focus of IVU, to teach one and reach many through teaching those surgeons.
Yeah, thank you very much. And I believe that's one of the aim of the collaboration of PAUSA with IVU. Obviously, it's going to be very beneficial collaboration. Thank you. We still have some few minutes left. The Secretary of PAUSA joined us not long ago, Dr. Mohamed Jallo. I don't know if you want to make some comments. Dr. Jallo. Dr. Mohamed Jallo, are you still there?
Thank you. Thank you, Dr. Lawal. Thank you, Dr. Jamie, and for this nice session. I know this is a very important topic. I know that our colleagues from Nigeria are in advance over most of the countries in uretroplasty, and that's why we have our expert, Dr. Lawal, today to handle the session. But I would take this opportunity to thank again IVUmed for this collaboration, for this great opportunity we have to be at our homes and learn high level of science from experts. And I would like to thank the speaker for the great talk. And we know, as we mentioned earlier, we are not going to stop. We'll be coming back soon to all of our colleagues to present the next session. So thank you, everybody. Thank you, Dr. Lauer. And thank you all of you who attended the session. Thank you, Dr. Lauer.
Well, thanks for the invitation. I wish I could meet you all in person.
Yeah. We dream of the time where the world reopen and where we have all of you guys come and share our warm weather and share the need to learn, the enthusiasm of the patient or for our professional, and share all this great experience with all of you guys. Thank you.
Yeah, thank you very much. We look forward to that once the COVID crisis is over.
Yeah.
Cut over to you.
Yeah, thank you so much. Thanks for attending and for organizing, and thank you so much, Dr. Myers, for presenting.
All right, thank you, Dr. Jeremiah, once again. Thank you, everybody, for attending.
My pleasure. Bye-bye.
All right,
bye. Thank you. Bye.
Bye.